Okay, so we've got a decent amount of people in here now. So for reading the ABGs, I have here like a link. It's a Nurse Sarah video on how to read the ABGs. But typically the way I do it, there's like a roam method and like a tic-tac-toe method. I think I probably align a bit more with the tic-tac-toe method, but I know the roam method has helped a lot of people. It's so this video will sh show you like all the different ways that um all the different ways that the ABGs are able to be interpreted. It's like a decently like long video, 25 minutes. But yeah, you guys can watch that on your own time. But yeah, I do recommend this video if you're kind of struggling to read it. But right now I'll go over like the normal values and everything. I'm not sure if you guys have like a standardized one that they went over. But if not, I'll just talk about the ones that are typically the values that are typically used. So do you guys know what the normal pH value is? Yeah, so 7.35 to 7.45 exactly. And the lower you go, the more acidic for the first exam, week 4. Let's see. Let me take a look because I did do a lot of these already. Let's see. Yeah, I was gonna do that next week then. Yeah. Oops. But yeah, 7.35 to 7.45. Lower equals more acidic and higher equals more basic. And depending on how the ABGs line up, even if it's within a normal limit, there's still ways for you to differentiate it between acidic versus basic. It would kind of just be going with like the splitting it in half and then going with the lower number of normal is acidic, higher number of normal is basic. Okay. So do you guys know the normal values for the PCO2? Yeah, so the nice thing about this one is that you do have that pretty much the same numbers here going on. So 35 to 45. And this CO2 is going to be kind of representative of respiratory. And another way to think about it is it's going to be, I would recognize it as like representative of respiratory and like acidity. So what does that mean? It means in terms of your matching, if you're, so one of the things you're doing with the ABGs is you're matching base to base or acid to acid with your pH and either your CO2 or your bicarbonate. So your CO2, when it matches with your pH, is representative of a respiratory imbalance, either respiratory acidosis or respiratory alkalosis. And your CO2 is also like a basic, an acidic substance. So a higher number, um, so in other words, a higher number, higher CO2 equals more acidic. Okay. So whenever your CO2 is high, that's considered acidic. Whenever your CO2 is low, so under the 35, then it's considered basic in terms of doing the comparison between the pH and your other values. Okay. What about the bicarbonate? What's the normal value for the bicarb? Yeah, 22 to 26 is the ones that I think is going to be more tested on. Depending on where you go, again, all of these values could be different depending on what hospital you're at. I've seen 22 to 28 on some, but I think 22 to 26 is what they'll be going for in this class. So this value is more representative of metabolic and base. So in other words, metabolic and base. So in other words, a higher number of bicarb is considered basic, and a lower number of bicarb is considered acidic. Okay, so higher CO3. Okay, and again, when I say representative of the metabolic, whenever you're able to match your pH to your bicarb, it's indicative of either metabolic acidosis or metabolic alkalosis. There is such thing as a mixed imbalance. So someone could have respiratory acidosis alongside metabolic acidosis at the same time. But for nursing school, you really just have to worry about the basic ones. I think as complicated as they get is determining whether something is a complete versus incomplete um, compensation, which we'll go over in a little bit. And then the PO2 is not like something they really focus on in this class, but I just wanted to have like the normal value. So for the PO2 is 80 to 100. So the partial O2 is 80 to 100. The lower number, you'll see the person struggling a bit more, and this number will become a bit more relevant once if you guys end up learning about ventilation. So when the vent for the ventilation chapter, this number will be used kind of as a guide for when uh when it's considered appropriate to put someone on a ventilator. But any questions so far? Is there anyone that's kind of that struggles to do the interpretations for ABGs and would like some like assistance with that? Okay, cool. So, like I mentioned before, I did include a section on anion gap and thyroid labs. I did see on the your guys' SLOs it mentioned like other forms of acid base imbalance uh, on there. It did make a mention of thyroid labs, so I included this here. However, I really doubt that they will test on it, but it's kind of technically there, so I did include it, but I do think that's additional info that you guys don't really have to worry as much about. But I think you guys already got some information on thyroid. The main thing to kind of think about here is like if someone has hyperthyroidism, everything in their body is going up. So they have higher respiration, higher heart rate, higher metabolism. So um, a typical case of hyperthyroidism that's unmanaged, the higher respiration count, the higher respirations means that they're outputting more CO2 out and breathing in more. So that's where they could get respiratory alkalosis. Um, while other things that are happening with someone has unmanaged hyperthyroidism is they'll be bouncing around, their GI tract is going to go down faster, they're going to be sweating more. So sweating and diarrhea that can lead to a loss of some electrolytes, loss of acid. So that's where metabolic alkalosis can come from. And then there's also if they are in a thyroid storm, so severe imbalance to the point where they're spiking like 103-degree fevers. Their metabolism is they have such a high metabolism that they are going through metabolic acidosis. Just their body's unable to keep up with the demand, and they have lactic acid buildup. And then on the other side with hypothyroidism, and if it's very, very unmanaged, then their whole body slows down. So they have a decreased heart rate, a decreased respirations, decreased GI movement, all that stuff. Decreased respiration rate could lead to some buildup of carbon dioxide, so respiratory acidosis could happen. If they are in severe hypothyroidism, they call it a myxedema coma, then their body is so slowed down that instead of having hypermetabolism like in a thyroid storm, they have a decrease in perfusion, decrease in all their bodily functions, which is why it's called a coma. Like they basically get put in a coma because their bodies are unable to keep up. But then the lack of proper perfusion leads to lactic acid buildup, which can cause metabolic acidosis. So again, I don't think you'll need to know that detail, but I did see the mention of thyroid labs somewhere in the slows. So this could be used for reference for that. And then I included this thing on anion gap, which I really don't think they will test you on, if I'm being honest. I think this is a little too much for right now, but the information that you would want would be here. Has anyone ever encountered like an anion gap in clinical? Like just seen it in the lab values?
I've seen it for patients with sepsis.
Yeah, exactly. So patients with sepsis, they would also check the anion gap. One of the most typical things that we'll see it for is also like DKA. So the basic idea of an anion gap is you're taking some of your electrolytes. So you have your sodium, which is your positively charged, main positively charged electrolyte, and then kind of doing a subtraction from that, from the addition of your chloride, which is one of your main acid base compensators, and your bicarbonate being one of your buffers that helps to decrease acidity. And the idea is if you have a bunch of extra acids in your blood, um, that this number will be thrown off because the extra acids is causing your body to use up your bicarbonate in order to neutralize it. So this number will be thrown off. There will be less to subtract from the sodium, which leads to a number higher than 12, which is when you have that high anion gap acidosis. So it is kind of complicated, which is why I really don't think that they're going to go over it for now. But I did include it because it is technically acid-base imbalance. So if this isn't tested on or anything, it's like a little bit of a head start. But if it's confusing, don't fret up too much about it. It's not something you really need to know at the moment. Yeah. And then here I have a written like a little overview for kind of the compensation. So the main thing to really know about is that respiratory, the compensation is obviously done by the lungs, and it's going to be managed through either your body breathing faster or breathing slower. And the big key thing is that it is it's faster acting, so it's going to be one of your fastest ways to adjust your acid base, but it's not going to be the most effective way of doing so. But part of the reason why, when someone's having a panic attack, you have them try to slow down their breathing and try to breathe in through the bag, to like a brown paper bag, is another to try to stabilize their acid base with the respiratory system. Uh, someone having the someone having like a DKA, they do the small respirations just automatically. It's a way for the body to regulate the acid base because if they're acidic, because of the ketones due to the DKA, their body's going to try to get rid of some extra acid in the CO2 by breathing out more. But like I said, it's fast acting, but it's less effective over long periods of time, as opposed to the metabolic side, which is regulated by your kidneys primarily, but there's also a play in it by the liver and the pancreas. So the way this works is that your body will either get rid of the uh, H plus, which is the acid, basically, or retain some of the bicarbonate, which is again, your main buffer against acid. Your liver will contribute by breaking down lactic acid, and your pancreas contributes by being the producer of the bicarbonate, which is helping to decrease the acid. So the main reason I included the mention of the liver and pancreas is just so that for some of the causes, it ends up making more sense now that you know that they're involved in the process of managing your acid base. So if you have problems with your kidneys and your liver, or your liver or pancreas, you can have issues with your acid base as well. And the thing about this metabolic regulation, is that it is very effective, but it is slow acting. So kind of here, the respiratory side takes minutes to hours to start making a difference, although it'll be a small difference. But the metabolic side will take a lot longer, multiple hours to days to start really working, but it will have a longer effect over time. Okay. Are there any questions so far on anything? Is there anything that appears a little foreign or a little bit different? Anything that you feel like the professors, Mr. Robbins, emphasized that I haven't touched on yet? And then what I'll go over is just the specific types and then go over their cause and treatment. All right, sounds good. All right. So respiratory acidosis. So this would be the retention of too much carbon dioxide. So what are some possible causes that you guys can think of where that would happen? It's people retaining too much CO2, not able to get it out. Yeah, COPD is a very common one. Respiratory depression. Yeah, exactly. So maybe opioid overdose, all of that stuff. Perfect. So respiratory depression could, yeah, due to various different factors. Trauma. Yeah. So specific like chest trauma. So that would kind of lead into the term of like acute respiratory failure. There's also they call they have ARDS, which is an inflammatory response. So you could have acute respiratory distress syndrome. Respiratory distress syndrome. And I'm not sure when they'll go over that with you guys, but it's kind of like a critical care thing, a big inflammatory response. So it can occur due to sepsis can lead to ARDS. You can have near drowning events. All that stuff can lead to ARDS. Just a huge inflammatory response that leads to fluid shifts, and then you have your lungs kind of being uh, unable to kind of keep up. Neuromuscular conditions, yeah. So people with certain conditions, they could have a struggle to get proper respirations out. So maybe like ALS, Lou Gehrig, I think that one's Lou Gehrig's disease. Yeah, ALS or um, other things similar to that. Maybe some Parkinson's where they kind of struggle to, they have the rigid movements, they can struggle, things like that. Neurological. Okay. But yeah, so there'd be a retention of CO2 just either from difficulty. I'll include asthma as well. Just if you're having like not like a it'd be more like an unmanaged asthma, like an unmanaged asthma as well. You said chest trauma. Yep. So chest trauma, drug overdose, neuromuscular. All right, perfect. Okay. So what do you guys know about like how to manage it, how to treat it, and then we'll go over everything as well. Yeah, so that's gonna be your main thing is treat the underlying condition. So how would that like what would you kind of go with that? What are some things that come to mind? Bronchodilators, perfect. So that would include things like your albuterol, that's your rescue inhaler. Yeah, that's great. So Narcan. So we have the Narcan for opioid overdose. And one of the great things about Narcan, it's a very safe medication. So if you're wrong that it's like it doesn't hurt, you can pretty much spray as much as you want. It'll reverse the overdose, and you can't really overdose yourself on Narcan either. So it's a very safe medication. Steroids can help to kind of decrease some of the inflammation with like the ARDS and everything. I could see that for sure. Steroid. Okay. So other things I would include as well would be to provide some O2 support. So there's too much CO2 buildup, so they might need a little bit more O2. So people with asthma, people with COPD though, you want to be a little bit careful. Careful with those with COPD. Granted, everybody that has really bad COPD is probably on O2, but you do have to be careful with O2 just because you want to keep them um, keep in range. Do you guys remember what the range is that you really want to keep them at for their SAT O2? Yeah, 88 to 92. Oopsies. And do you guys remember why that's the case? So do you guys remember what would happen? Keeps them in the hypoxic drive. Yeah, it's related to that. Yeah. So I'll write it down here. Keep it in range. COPD have a hypoxic drive. So just for a re-explanation on what that is. So when you and I breathe, we have that feeling that we need to breathe not because we're low on O2, but because your body wants to get rid of carbon dioxide. Because remember, carbon dioxide is a waste product. So the main motivator for breathing is actually to get rid of your waste product, get some O2 because your body needs it for the Krebs cycle, and then that's it. But people with COPD, because they retain carbon dioxide, their bodies chronically have a high buildup of carbon dioxide. So the chemical receptors that kind of tell them it's time to breathe kind of change over and adapt, and their bodies now no longer decide to breathe because of high CO2. Instead, now their bodies breathe um, because their body senses that they have low O2. So when they're given too much high percent oxygen, too much the flow rate is too high, their bodies will be tricked into thinking that they no longer need to take respirations and they could stop breathing because the O2 is on too high. So that's the main reason for that. Um, so they will stop breathing. Okay. Okay. What are some other things that might help get rid of some of the CO2 out that you could coach someone into doing? Yeah, pursed lip breathing. That one's really good to get rid of some CO2. Turn cough, deep breathe. Yeah, all of that can help. Pursed lip breathing. I like that. You could also tell them to hyperventilate. So just start breathing. Um, you can have them have deep, faster breaths. Tell them to pursed lip breathing. Tell them to breathe out like they're trying to blow a candle. All of that is very helpful. Yeah, so that's good education there. So that's perfect. Some things I'll include under the treat the underlying condition. I'm going to include, if it's really bad, you can have mechanical ventilation. You can have your BiPAP slash CPAP. That's they call that the bridge to ventilation. And then if they need to be ventilated, that's something we can do as well. And then one of the interesting things with this one is I'm going to include fixed electrolyte imbalance. So this condition, respiratory acidosis, has the potential to lead to hyperkalemia because your acid ions flood into the cells and kick out the potassium. So you will see that some of these acid base imbalances also lead to some electrolyte imbalances as well. Okay, but that's pretty much the main thing here. So the main thing is just kind of knowing your causes. You guys were very good on and quick on that, and then treating the underlying condition like you guys mentioned. So the use of the bronchodilators. I really like the addition of the Narcan that you guys mentioned. corticosteroids, 'cause some of these are inflammatory processes that can impact this. This won't be for everyone, for everything, but it definitely helps for that. Helps for the COPD because they have that inflammation. They have hyper expanded lungs. Uh, it's difficult to breathe. Um, this will definitely be helpful for someone in ARDS as well. Just like a high dose corticosteroid. For COPD, they probably get it more like inhaled corticosteroids for long-term treatment. But this can also be like IV corticosteroids um, for assistance on that. And you guys knew like some of the good teaching for how to start compensating um, to try to help with the acid-base imbalance. So to try to get rid of some of the CO2. Now, something that they do mention is that kind of like for your respiratory imbalances, one of the main things is that you'll have kind of like the opposite side due to some of the compensation. So what that means is that if you're having a respiratory imbalance, your metabolic side, so your kidneys, will be kind of the main thing that's working to fix it. So for those people that have COPD, some of their ABGs will be kind of like that respiratory acidosis with partial or with complete compensation. They're in a stable, they're more stabilized with their condition. They still have acidosis, but their bodies have stabilized because they've managed to compensate. But um, but yeah, so with any respiratory process, you're gonna have the metabolic side play a big role in being the main thing that's acting to try to fix it. But you'll also notice that in our actual like quick interventions, it's mainly going to be it's gonna have a big focus on the respiratory side for just because of the factor that it is fast acting. It's a fast acting way of trying to help because you really can't control someone else's kidney function. Like you can't really prod them to be like, okay, start working now, but you can help them with the respirations. And it does have that benefit of being fast acting. Okay. So now respiratory alkalosis. So what are some things that come to mind that would cause the lack now of CO2? So too much, getting rid of too much CO2. Yeah, a big one is going to be anxiety, panic attacks, hyperventilation. Exactly. So hyperventilation, and we can include anxiety, panic attacks, pain, perfect. Pain is definitely one of them. So pain can cause you to breathe a little bit faster. And I might also include like infection. So someone's having like a really bad infection, they could have that fever, they could have extra faster respirations. If it's a respiratory condition, they could have also hyperventilation because of that. But the main thing is going to be hyperventilation. You're getting rid of too much CO2. So this is gonna kind of fall back on similar things. So treat the underlying cause. So what would that look like? What are some of your coaching that you can do for this one? Okay. Yeah, taking slow deep breaths. The reassurance, it definitely is good. Because I know if they're having like an anxiety attack, the reassurance can definitely help. So it'd be kind of like a mix of the reassurance alongside like the coaching. So taking slower, deeper breaths. So kind of
I
like the
have a
idea.
question,
Yeah.
Diego.
Mhm.
I, I I know I read in the book or somewhere that is said to for the bag to breathe in a bag, but I know it's not recommended. Would that be? something to do? Would that be something that we can do or no?
I mean, I'm not sure of what the current evidence-based practice is, but it's definitely something that's still done.
Hmm.
The brown, like breathing into a bag.
Okay,
It is something that's still done, but
got it.
I'm not sure what the current evidence base is on that. I know that
Okay.
when I was taking the class, we did go over like breathing into like your cup hands or like into a bag.
Hmm. Got it.
Yeah, did they ever
So if
mention
it
any of
comes out
that?
on the test, it's basically.
Yeah, I'm not sure. Maybe clarify this with the instructors then for that.
Got it. Thank you.
Yeah.
I think they said that um it's still recommended, but only if there's no hypoxia present
Oh,
concurrently.
got it. Got it. Got it. Thank you.
Oh, that makes sense. Yeah. Okay. So yeah, I'll add that note in there then. So we can rebreathe back CO2, which makes sense, right? So if there was hypoxia alongside of this, then getting extra CO2 in is gonna be counterproductive. Because sometimes you do have respiratory alkalosis that precedes respiratory acidosis because sometimes you have like people having asthma attacks where they're actually going to be in that state where like their airway is starting to close and they're going to be hyperventilating to try to make up for it. So they'll have a brief instance of al being alkalotic before their their kind of compensation fails, and then they go into a respiratory acidotic state. So that would be one where like you wouldn't want them to breathe back in the CO2 because that's not going to help them at the moment. The moment at the moment they might be technically alkalotic because they're hyperventilating, but over time they're not going to get the O2. So that's why you would actually fall back on this side here and try to just open up the airway rather than these interventions, if that makes sense. Okay. Okay, and then something else you could just do, you could provide O2 support if needed. Okay. Any questions on any of these so far? Okay. Metabolic acidosis is probably one you guys are familiar with just due to DKA. So that's going to be like a very common, one of the ones you'll probably see a lot. Can you guys think of other possible causes? Aspirin overdose, definitely. So some toxicity here. So we'll include DKA, we'll include toxicity. Diarrhea, so let that be a loss of base. Severe diarrhea, renal failure. Yep, went shock. So yes, so shock, some sort of shock or sepsis. Okay, and then I'll include a few other ones here. So we have as toxicity, aspirin is one of the key ones. I'm going to include some hypermetabolism. Yes, also the alcohol. Hypermetabolism, so burns, seizures, trauma, just from just severe trauma causing your body to go into overdrive, leading to like we talked before, like with the people that are hyperthyroidism, the hypermetabolism can lead to metabolic acidosis due to lactic acidosis. So lactic acidosis is going to be one of the big ones there. So then lactic acidosis, which can include, I guess I could do this, liver failure, and then that's when we have the shock, sepsis, hypermetabolism. So I guess that would be a way to kind of just keep it all together there. Okay, so this is kind of how that goes. So yeah, like we mentioned, the excessive ketones, DKA, so excessive ketone production, lactic acid buildup. So we mentioned how over here in the overview how the liver plays a role in the acid-base balance because it helps to break down lactic acid. So having liver failure can cause you to have lactic acidosis. Being in shock or sepsis, you get to a state where your body doesn't have enough resources to go around. It starts going into lactic acidosis, going into that anabolic pathway, and then the hypermetabolism, body's going too fast, not enough resources, so then it needs to go into that anabolic and anaerobic metabolism, which builds up lactic acid. Renal failure, we mentioned how the kidneys are one of the main contributors to your acid-base balance. So if your kidneys aren't working too good, then you're going to have issues with that. And then toxicity, the aspirin toxicity can lead to like kind of like the hypermetabolism as well. And then for the side of your loss of base, so this is like a gain of acid, and then a loss of base, severe diarrhea. You're losing, um, you could lose a lot of base from your diarrhea, from having severe diarrhea, which can also lead to some dysrhythmias because you're also losing electrolytes. If you recall, the potassium can be lost through that electrolyte balances. Another one I'll include is pancreatitis, just due to um, bicarbonate, the pancreas producing bicarbonate. So, something wrong with your pancreas could also lead to an acid-base imbalance, due to decreased bicarbonate. So, if you have less of your bicarbonate, that means you have a harder time decreasing your acid levels. Okay. Okay. So the main treatment for that pretty much gonna include the same similar thing as just always treat the underlying cause. So what are some of those interventions here, taking into account some of the causes for it? Yeah, so for sepsis, shock, or mostly for sepsis, we can have antibiotics. Sure. IV fluids, yeah. So for sepsis, antibiotics, IV fluids. For um DKA, we can have insulin drips, insulin drip, IV fluids. And I'll include something here like the fluid resuscitation. Do you guys know which fluid is technically preferred for this sort of imbalance? Not D50. Uh, D50 would be more like if someone's hypoglycemic. So it's actually lactated ringers. So lactated ringers has um I think it has some bicarbonate in it. Just the composition of it helps to decrease some of the acid buildup. So let me see the exact composition of that. Yeah, it does contain lactates, which is so the main explanation here is that lactated ringers, as it's in the name, lactated ringers, has lactate in it, and lactate is converted by the liver into bicarbonate. So don't confuse lactate with lactic acid. They are different. So the lactate in the lactated ringers becomes bicarb, and we know bicarb is a buffer. So buffer to decrease acid. So that's the main reason for that. And that too, replacing lost electrolytes. Yes, exactly. So not it definitely bicarbonate can definitely be given, but it should only be really given in severe metabolic acidosis. I believe the evidence-based practice was that it wasn't actually increasing outcomes in less severe cases. So they only really do that for severe cases like Eric mentioned. So yeah, bicarb used to be, I think it used to be like a very standard thing that they would always be doing, but they ended up finding out it didn't really improve outcomes outside of like really severe cases. And it probably came with more complications in the case of more manageable acidosis. Okay. And then something else I'll bring up here, maybe just dialysis for kidney failure if needed. And if you remember from before, too much acid drives potassium out of the cells, leads to hyperkalemia. So, fixing electrolyte imbalance as well. Okay, any questions so far before we do this last one and then we start doing some practice questions? Okay. So metabolic alkalosis is probably the least familiar one. Everything else here we've probably kind of at least heard of before. We've definitely heard of COPD and all this other stuff. We've heard of people having panic attacks. We've know about DK and sepsis and all that stuff. But metabolic alkalosis is probably the least common one that you'll see. But can you guys think of some possible causes for it? And I'll kind of do the same thing, gain of base, loss of acid. So vomiting, yeah. So loss of acid would be like severe vomiting. Antacid overdose. So then that would be in a gain of base. So overuse of antacids. Makes sense. Yep. NGT suctioning. Yep. So that would be a loss of acid there. NG tube suctioning. Yeah, so the hypokalemia is kind of like a both ways kind of thing. So that could be it could be hypokalemia leads to metabolic alkalosis or metabolic alkalosis leads to hypokalemia. So it's like an interesting case there. I'll include it as like a separate little thing, but I'll include diuretics as well. So we have hypokalemia. It's like a cycle. Um, Hypokalemia can lead to metabolic alkalosis and vice versa. Just shifts in the ions. So similar case with kind of like the opposite case of like the acidosis ones, where you have uh, the acid kicking out the potassium. You kind of have the case where you're having the um, kind of like the potassium kick out the H plus, or you have it where you're already alkalotic and that leads to more potassium going into the cells, which therefore decreases the potassium in the blood. So it's like a cycle. But very typically, you'll have hypokalemia with the alkalotics and hyperkalemia with the acidotics. And then you can also kind of see from the loss of acid, all of these are included in your possible causes for hypokalemia as well. So like diuretics, you're losing potassium. NG tube suctioning, that can be lead to a loss of potassium. Severe vomiting can be a loss of potassium. So so that kind of all correlates together like that. So again, this is also going to be treat the underlying cause. So you can have them stop and reduce antacid usage, uh, and then replacing lost electrolyte and fluids pretty much. And they just want some sort of isotonic solution for this one. Any questions on anything so far? 'Cause now we can start doing some practice questions. Did they go over how to do the compensation, like partially compensated versus fully compensated? Okay. Do you guys have any questions or do you feel comfortable with that? Or is it like you'll find out with the questions? You feel okay? Okay. So let's try number one right now. Would you guys like to kind of go over it like me talking out loud and then putting in your answers together, or just kind of working it out on your own and putting your answer down? Okay, sounds good. All right, yeah, that's correct. So this is going to be a fully compensated respiratory alkalosis. So to kind of do a play-by-play, you take a look at the pH and you notice that it's technically within normal limits. So we'll keep that in mind for now. Your CO2 is going to be lower than your normal value, so that's considered basic. And your bicarb is a little bit lower than your normal value, so that's considered acidic. Because you have these imbalances here, you're going to consider instead of this as within normal, you're going to consider this as basic because it's closer to being basic than closer to being acidic. So then you match basic with basic. CO2 is an indicator of a respiratory issue. So we have respiratory alkalosis because your pH was technically normal. That means there's a full compensation going on. So that ends up being fully compensated respiratory alkalosis. Okay, so let's go ahead and try number two. Yeah, so you guys got through this one pretty quickly. So, yep, this is an uncompensated respiratory acidosis. So again, you have your pH, this is low, so it's acidic. Your CO2 is very, very high, so that is also acidic. And your bicarb is actually within normal limits. So your bicarb, because it hasn't been touched, and we have our match here, we have respiratory acidosis, and there's no compensation because we see that the bicarb hasn't yet been affected. Okay, we can do the next one, number three. Okay, yeah, uncompensated respiratory alkalosis. So again, our pH is going to be basic. CO2 is going to be basic. And your bicarb is going to be within normal limits. Match these two. This is CO2, so it's respiratory. So it's respiratory alkalosis, and there's no compensation because your bicarb didn't change. Your third value didn't change. Okay. So let's try number four. Okay. So, yeah, you guys didn't get thrown off by the PO2 or the SAT02 values. I included that there just partially to throw you off, and just in case they throw in some questions where it's like, what is this? And then what's a possible cause for this? So what does this kind of look like? So you have respiratory alkalosis, and what do these values kind of hint at? So there's some hypoxia. Yeah, so what do you think? So going back to like your list of possible causes, what do you think is happening here, and how would you try to approach it? How would you try to treat it? Maybe, maybe some infection. Anything else that we might have touched upon a little bit, where you have hypoxia and you start out alkalotic? So kind of think about what would cause you to be releasing a lot of CO2, but not getting in enough O2 in order to have this number go up, even though you're breathing so much, you're attempting to breathe so much. Sure. So if you guys recall, we kind of went over this a little bit here. Respiratory alkalosis. We talked about how if the patient is hypoxic, not to do the brown bag or cup hands method. And then I touched upon how sometimes, like when someone's having like an asthma attack or having like their airway start to close off, that they will initially be alkalotic because they're trying to breathe in really a lot. So they'll be making an attempt they'll be hyperventilating to try to get O2 in, but because they're also breathing in so much, they're actually getting a ton of CO2 out. So this is one of those scenarios where they are getting a lot of CO2 out without getting much CO2, without getting as much O2 in. So this is kind of like maybe more like an asthma attack, like early asthma attack. And this person would then eventually go down to being respiratory acidosis. So this is one of those scenarios where even though this person is currently alkalotic, do you guys think we should, with this person with these stats that you see right here, we want to do the brown bag or cup hands method of retaining CO2? No. Yeah, so that's kind of there's a little bit of nuance there. I don't know if they'll make it that nuanced on like a test or anything, but you guys can kind of see how there's some nuance to it. Yeah, so that's a little something a little extra to think about there. Okay. Let me see if we actually go through all of these or if maybe Um, let's kind of skip down to 7 because I'm gonna give you guys this document so you can do the rest on your own, just to so you guys can go a little early. Let's try do number 7. Yeah, so this is uncompensated metabolic acidosis. You have the pH, which is acidic. CO2 is um so this metabolic, right? Yeah. Within normal limits. The 19, which is considered acidic because it's low. Because this matches with your bicarb. Therefore, it's a metabolic. So metabolic acidosis, because your CO2 has not changed in value, it is not partially or fully compensated. So in this situation, you have their SATO2 is really high. So this person might be getting some oxygen supplementation, and it might be a little too much. And then let's do 8 and 9, and then call it and then and I have the answers here as well for you guys, and then kind of just call it a day, I think. And then if you guys have additional questions, we can answer those as well. So number 8 now. Okay, so yeah, this is going to be a partially compensated metabolic alkalosis. So you have your pH, which is basic. Your CO2 is low, so it's basic. Your HCO3, your bicarb, is low, so it's considered acidic. So you match basic to basic. CO2 is respiratory, so this is respiratory acidosis. And your bicarb, your third value has been affected. So this is then showing that there's some compensation. But because the pH did not go to a normal value, this is a partial compensation. Okay. So we see this person has their these values here. So they're kind of stable. They're starting the partial compensation. They might need a little bit more support, but they're close to being stabilized. Then number 9. So yeah, this is going to be a partially compensated respiratory acidosis. So your pH is below normal, so this is acidic. Your CO2 is high, so this is acidic. Oops. Your bicarb is higher than normal, so it's basic. And you match acidic to acidic. CO2 is a respiratory factor. So respiratory acidosis, but your pH is still abnormal, so this is only a partial compensation. Okay, so that's pretty much it. Obviously, there's a few extra questions here if you guys really want, but it looks like you guys got it down. If there's any extra questions, and the file will come, of course, with the answers here as well. Are there any questions on anything that we covered? And is there anything that you feel like I didn't cover that you would like to know? And I'm gonna save this as a document so I can give it to you guys. Thank you, thank you. All right. Can you guys see and download the file? All right, perfect. And then for next week, I'll be covering. I already have the first 4 weeks for you guys done. Your kidney, AKI, all that stuff. Oh, let me actually screen share that. So yeah, I have the first 4 weeks already prepped. I don't think I have any, but I can make some. This one's gonna actually take a little bit. It's pretty long. I can give you guys like a sneak preview of how I'm planning on doing it. There's a lot of functions for the kidneys, so I was just gonna go through a summary of the kidneys. Probably only a little bit of student interaction with this one. It'd probably just be me mostly just kind of going over it, going over mostly like what are the functions. You guys will be tasked with like kind of which electrolytes are thrown off, how they're thrown off, and stuff. We'll go over the diagnostics, and then we'll go into specifics on uh, acute kidney injury, as well as chronic kidney disease and dialysis. So this one will be a little bit long. I'm not gonna lie. We'll probably go the entire way for this one. And as for questions, let me see if I already have questions. Let's see from the last class. Kidneys, like week 6? No. I guess I already have questions. All right. I'll take some of those and maybe add a few more. But yeah, that's pretty much it. Any questions at all?